All right, so how do you choose the correct size BVM and how do you know that you're getting good ventilation? Well, there are adult, pediatric, and infant size BVMs and masks. Now, again, you want to choose the one that is going to be the best size, the best seal for your patient, and going to provide the best tidal volume for your patient. So what you see here is an adult sized bag and an adult sized mask, but you could use a pediatric sized bag with an adult sized mask because that's going to deliver enough tidal volume in most cases to see that chest rise and fall. So just kind of work with the equipment that you have if you are having to improvise. Now, this is considered positive pressure ventilation, which means it's increasing the intrathoracic pressure, and that's going to be require more volume to have the same effects as normal breathing, to see that chest rise and fall. And sometimes air can be forced into the stomach, which can cause gastric distension. Now, this is less of a concern when we have an advanced airway in place, as we're going to be really protecting the airway and forcing the air down the trachea where we want it to go. But when you only have one of these basic adjuncts in place, OPA or MPA, and additional air can be forced down the esophagus, it can lead to some gastric distension or that inflation there, which can lead to vomiting. And so gastric distension can be avoided by making sure that you're giving appropriate ventilations at the appropriate time. So one breath every 5 to 6 seconds for adult patient, one breath every 3 to 5 seconds for pediatric patients. And again, not overinflating the stomach. And if you do note that that abdomen is beginning to swell and we are concerned about gastric distension, it can be potentially relieved with an OG tube or an NG tube put in place if the patient is accepting of that, so that if they're a candidate, so that we can relieve some of that gastric distension. And that'll be talked about a little bit more in class whenever you guys are talking about the advanced airways. Now let's talk about CPAP for just a second. So that means continuous positive airway pressure. So just like BVM ventilation is positive pressure, so is CPAP. But the CPAP means it's continuous. And so this can be used on patients who are conscious and alert, but are having severe respiratory distress. And while this used to be used widely at the ALS level, it is starting to become more popular in use at the EMT level. And so let's talk about how this works and what it's used for. You can see in the picture how this mask is pretty much set up. It can be very claustrophobic feeling to the patient. So we're going to talk about some indications and contraindications for this, but this is what it looks like when it's placed on the patient's face. And it's making a really good and tight seal so that air is not escaping and is being forced where it needs to go. Now, the whole purpose here is that it's increasing the pressure in the lungs to open the collapsed alveoli. And so we can use this for several different reasons. Two of the most popular are going to be for COPD or excessive bronchospasm, so really severe allergic reaction, really severe asthma attack, anywhere we have that severe bronchoconstriction. And then also for CHF or pulmonary edema, where we're trying to move that fluid back out into circulation out of the lung tissue. Excuse me. So it can work in two different ways. If the alveoli are collapsed, then we can use this air to force them open, or if you've got alveoli that are full of fluid, we can try to push that fluid back out into the systemic circulation. So the patient must be alert and able to follow commands. So that doesn't mean that they are not tired or that their work of breathing is not bad, because a lot of times they are having severe respiratory distress, but they are still breathing on their own and they are still able to follow your commands. Generally, the pulse ox will be less than 90% for these patients, but again, we're treating the patient and not the monitor. So even if their SpO2 is 94%, but their work of breathing is really bad, their bronchoconstriction or their whatever you're treating this for, pulmonary edema, is really bad, we still can progress with this treatment. So remember, we're treating the patient here. Now, the patient cannot be in respiratory arrest, which means that they must still be breathing on their own. They cannot have any signs or symptoms of a pneumothorax or any external chest trauma, because this is already going to increase the pressure in the chest and could potentially cause a pneumothorax. So the patient can't already have one. The patient can't have a tracheostomy or one of those tubes in place that we just were talking about, because they wouldn't be effective. This mask goes over the mouth and nose. It's not designed to be going directly into the trachea. They should not have any active gastrointestinal bleeding or vomiting. Once this mask is placed on, it should not come off. And so we want to make sure that the patient is not going to vomit into that mask. And if the patient, again, cannot follow verbal commands or is not alert enough to be sitting up on their own, they would not be a candidate for CPAP. Now, when this is applied, you go ahead and cut this on with the oxygen. And when you apply this to an oxygen tank, you're going to set this to a setting, and that's measured in centimeters of water. And so when you're in class and you're physically taking a look at the CPAP, you will see what I mean by how you can turn up the setting on this and increase that pressure. Now, this will actually go from 5 to 20, but really 5 to 10 is the safest range that you want to stay at. Once you get over about 15, you're looking at potential damage being caused to the lungs. Okay, so we want to be very cautious in how high we're turning up the pressure. You can always add more. So I would say start at 5, and then if the patient is not improving, we can always turn it up very slowly. Now, some complications potentially from CPAP, the patient may find it claustrophobic. Again, your biggest key here is to talk them down, to relieve some of their anxiety by letting them know that you're providing this for them. They need this to help them breathe easier, and try to keep them as calm as possible. In some really severe situations where the patient needs this but is not tolerant of the mask, an ALS provider may provide a mild sedative to the patient. Again, they need to be fully conscious and aware of what's happening, but again, just to take the edge off of that anxiety, that is a potential option. Now, other potential things that could happen, it could cause lung damage like a pneumothorax. It can lower the patient's blood pressure. It could cause other potential deteriorations here. So we want to make sure we're closely monitoring this patient, that we get a 12-lead ECG prior to putting this on, and that we, again, are closely monitoring their vital signs: heart rate, blood pressure, lung sounds, respiratory rate, mental status while they have this on. If at any reason, or excuse me, at any point, for any reason, this needs to be taken off because the patient is not tolerant, or if they become unresponsive, you would take it off and you need to begin ventilating with a BVM. All right, so we have got to trade positive pressure for positive pressure. If we take this off and we do not replace it with the use of that BVM, the alveoli are going to collapse or come right back full of fluid, and that could be way worse for the patient when they snap back closed all of a sudden like that. So we definitely want to be really cautious if we are considering taking this off for any reason. Now, a couple of special considerations here. We talked briefly about the stoma or the tracheostomy tube being in place. Remember that if they have this, then we need to be ventilating through the tube if the tube is in place. But if they have the stoma or the hole, which is what we see here, but no permanent tube, then we are going to use an infant or a child mask if we're ventilating with a BVM to make that appropriate seal over the stoma. And you will see some test questions that ask about that as well. And then lastly, let's talk about airway obstruction here. So we talked about this during CPR and foreign body airway obstruction, but just to refresh your memory, if the patient is alert and moving air, meaning they are still coughing or moving air at all, then we want to encourage them to continue coughing or talking and not intervene. If the patient has a complete airway obstruction, meaning they are not moving air at all on their own, then if they're still awake, if this is an adult patient, we would perform the Heimlich maneuver, and we would continue that Heimlich maneuver until either the object comes out or until the patient becomes unresponsive, in which case we would begin CPR, looking into the airway before providing each ventilation to make sure the object has not become dislodged in the mouth. If this was an infant patient, again, with a complete obstruction that's still awake, we would do the 5 back blows and 5 chest thrusts, alternating those until such time as the object comes out or until the patient becomes unresponsive, which we would move to traditional CPR, looking into the airway before delivering each ventilation. So that's it for this PowerPoint, and we're going to jump into talking about some advanced airways, the different types of tubes, how to confirm those tubes, and when we would use them in the next video.